So this way ahead thing, we have been, we always, whichever era you are in, you start thinking, what ahead, what next. So I think my generation is possibly very, very lucky to have seen this change, that we did nothing apart from karyotypes, and then now we do whole genomes. So this was a dream when we were in the karyotyping era, that could we really see the whole sequence, and can we really find out every base change and so on. And still, after achieving that, there are still so many more questions. And sometimes with advancement, you find more questions. And so there is always a way to think what is way ahead, where things are going and where things can go. And that's very interesting. That's the kind of excitement that keeps you going. Because if you knew everything on the earth one day, I don't think life will be very interesting from the next day. So it's always good to think. So this was the typical idea about genetic disorders, that they're incurable, they're lifelong, they're passed on. And so the lot of feeling of helplessness, guilt and anger, and they have some expensive fancy treatment options, and there's poor awareness amongst public and professionals. And people then read about Human Genome Project and designer babies and so on. So then there was always some bad notion going on with genetics, that geneticists in the labs are trying all weird things. They want to create designer babies, they want to play God, they want to change your genes and so on. But we know that it's not really that. There is a fantasy part to it, because it's really a very, very fantastic science, I would say, and a lot of things that we don't still understand. Medical genetics is like, I say it's a genie that comes out, because there are too many things going on there. It's an original science, unlike skills that became science. So I don't mean to compare or show one branch down upon, but people were always delivering. Before you became obstetricians, the people were always doing something to heal fractures. Then there were orthopedic surgeons, but genetics science as such was discovered in the labs, and then its use started for the patients. So rapid pace of advancement, difficult to keep pace with. Poor representation in medical curricula across the world, even today, I guess. And only a minuscule proportion of health professionals deal with it. So if you compare how many geneticists are there in the country, properly trained geneticists, they are, I think, still in 3 numbers max, not more than, we don't even have 1,000 geneticists, I think, for our population. From personalized medicine to policies for population. So the use is so much. You can go to pharmacogenomics, deal with one person, or you could have policies for populations, like what condition to screen, say for newborns or for reproductive carrier screening and so on. And from monogenic rare disorders to polygenic, multifactorial, and now even epigenetic disorders. So this particular science has a vast scope and span, and that's why it is difficult. So what are the clinical benefits of genetics in medicine? So a new taxonomy of diseases based on mechanisms, not phenotypes. So we now know that what are the mechanisms of disorders, and so we can group them accordingly, and then treatments can be focused accordingly, because these genetic mechanisms can work as target molecules or targets for treatment. New drugs developed rationally from understanding the pathogenesis. Personalized medicine, as you would have maybe heard previously, that for better response, for lesser side effects. Risk factor analysis to facilitate environmental modification before developing symptoms. So if you have some SNPs in your genes that predispose you to cardiac problem or whichever problem, and if those are related to nutrigenomics, say taking folic acid or taking calcium or taking something else, that is likely to modify your genetic risk, then that also is now a part of medical genetics. And this is Dr. Phadke's patient paper way back. And at that time, 2002, 85% could not consult correctly regarding common autosomal recessive conditions like thalassemia, saying that both parents need to be carriers and child will then be affected, 25% chance and so on. And that included all sorts of doctors, from residents to professors. So that was the situation. And has the situation changed? We don't know yet, but I guess the interest has definitely increased, and I'm sure there must be some positive change in the attitude towards genetic disorders at least. So we all know that we all have taken oath, do no harm. We said that yesterday also. And so what are the implications, keeping in mind this particular oath that we have taken? As we said, in medical, pharmacogenomics, diagnostics, cancer genetics, exploring the genomes of various organisms and trying to understand how we have evolved and learning from that, gene therapy, and then the socio-ethical legal aspects, that some of which we saw yesterday. So it is very important that we don't forget the educational part of it. And education always is very important for any medical branch. And it's not your own education. Wherever you go, some of you are obstetricians, pediatricians, pathologists, whatever you are, maybe you can always help your colleagues to understand. If you get such a case, do share it with your friends, talk about it, so that the knowledge and the curiosity about what you're dealing with does increase. People feel that there are communication challenges for non-geneticist physicians. And there is one reason that has been quoted, it's confusing genetic terminology. There are so many terms you might have heard during the course for the first time, proband, consultant, and such things, which we typically don't use in a phenotype, genotype, etc. Overwhelming volume and complexity of information. So even if you read that microarray report, if you attempt to read the whole report, most clinicians say, where is the line that will tell me whether this is abnormal or normal? And that's the end of report reading, right? But if you really wanted to read or go through the whole exome report, where everything is mentioned, that this is the variant, what is its position, what does it do, what type of mutation it is it conserved across the species? It's too much information when you're sitting in an obstetric OPD or pediatric OPD, and you think that it's too much. So we don't really understand this, and forget about explaining it to the patient. Difficulty in finding appropriate words for offering simple explanation. So you have understood whatever you want to say, but your lay patient who doesn't understand English maybe, or understands usual English but not scientific language, to explain this recessive inheritance and anticipation and all those phenomena in your own mother tongue or the patient's mother tongue sometimes becomes difficult. And I think it will be a good exercise if you can, in your spare time, try and find out how you can explain a given situation to patients in their language or in whichever language you are comfortable with. Lengthy technical information doesn't mean much to patients. At the end of the day, of all your explanation, they will ask the same question, ki sab theek hai na, ya kuch karna hai. Discussing risks is difficult because it may trigger undue anxiety. We have seen so many Down syndrome patients at 8 months or 1 year, and then they tell us that this is for the first time they have been told that the child has Down syndrome. Most pediatricians and obstetricians also maybe here will agree that you can spot Down syndrome cases on day 1 also technically. And then everybody wants to delay that diagnosis because they don't want to break the bad news. So they will keep on saying ki haan, theek hai, nothing, maybe looks slightly different. Then it goes on ki dekhenge 3 mahine tak if the baby is picking up. If not, so everybody's mindset is now ready ki kuch to problem hai. And then geneticist hits the last hammer ki haan hai Down syndrome. So whether it is right or wrong, I don't know. Every family is different. Every clinical situation is different. I don't mean to say that the moment the baby's head comes out and you see there is Down syndrome, you declare that. But there has to be a real kind of giving an idea to the patient what's going on, so their expectations can be realistic. But nobody wants to do that. And with many genetic disorders which don't have treatment, your diagnosis is kind of giving a punishment or giving a verdict that tells you that this is lifelong and even it is going to be transmitted to the next generation. Some may dismiss the value of NGS, at not every finding might be actionable, and there might be no finding at all. We saw some cases yesterday that after spending so much money, you might not get an answer, or you get another question instead of getting an answer. So some people feel better not to go in that direction at all. There are so many doctors, obstetricians who feel that all the screening tests are useless, because whatever test they have ordered, triple screen and double screen, they have never found a high-risk patient actually to have Down syndrome in their practice. So they feel I'm just wasting people's money and I don't really believe it in, and I don't want to do it. And then many a times the opinion changes when they see their first Down syndrome case, which was missed because this was not done. Now, I don't claim to say that prenatal screens pick up each and every case. We all know they are screens, they're not diagnostic tests, but there is a reason why things come up. So what can be done? So educating physicians starting from medical colleges, having interest in patients' ideas about their health and choices is very important. And I think only after I started learning about genetics and got into the genetics program, I realized this. Until then, as doctors, we are so happy and excited about our own knowledge and our own ideas that we forget to think, what does the patient think? You are giving some great diagnosis, you are genius, all that is fine. But how does the patient take it? And does the patient want to know it? And how does patient accept it and deal with it? So all the other side of the table aspect comes when you are into counseling. Allow patients to talk without interruption. Now, I know that not all of you are geneticists as such. So we have 45 minutes or 1 hour appointment with one family. You might be seeing 20 patients in 1 hour, I don't know. But if you're dealing with a case which needs counseling, please spare time and talk to the patient, and more importantly, hear, listen to the patient. Encourage patient to ask questions. Most genetic counseling sessions end with the geneticist or the counselor asking that, have you got what we have said? Do you have more questions? Maybe you don't have questions right now, but if you have further questions, this is the number or email or whatever, when you can always call us back and get your questions clarified. And online training modules for doctors and patients. And I think somebody must have already said that SIMG also has online modules if somebody is interested in reading. So I always feel that because we have taken genetics out as a separate subject, as we did for preventive and social medicine, this is something that is a hindrance to people getting interested in that. I think preventive and social medicine is a part of medicine. When you're talking about diabetes, prevention is a part of it. You cannot take it out as a separate subject, or it could be infectious diseases. Similarly, genetics is there for all genetic disorders or all disorders that could have a genetic basis. So primary prevention helps to prevent disease or injury even before it occurs. So avoid disease to recur or occur. Pre-implantation, prenatal diagnosis, expanded carrier screening are all steps towards kind of primary prevention in the next generation. Then there is secondary prevention, aims to reduce the impact of a disease or injury. So early diagnosis before symptoms appear, and pre-symptomatic management, like you would do newborn screening. So the baby is already born. But if you screen the baby and if you find something actionable, the disease can be completely prevented. Like that yesterday's patient who has no symptoms, but he has Wilson's disease. So therapy with penicillamine is going to help him significantly without any symptoms really being developed. Then comes the tertiary prevention, which aims to soften the impact of that ongoing illness. So timely diagnosis and whatever treatment is available, that all can help. So I think people feel that genetics is something very fancy, but I think it is just the same as preventive and social medicine, actually, at a different level. Changing approach to genetic testing. So traditional phenotype-based approach of clinical geneticists. So there are meetings, international meetings happening even today, that all unsolved cases are presented to national or international experts, and then they look at the face, and then they all try to come up with a diagnosis that it looks like this, like that, and so on. So dysmorphology expertise was extremely necessary to become a clinical geneticist. Now you may not even be a geneticist, but you can still use the genetic test, because now the the flow chart is changing. You have the genotype first, and then you see if your phenotype matches with that genotype. Again, there are ifs and buts and rights and wrongs, but this is how the world is going. So you need not be a clinical expert sometimes, a clinical dysmorphologist as such, but still you make a diagnosis of some fancy genetic disorder based on what the lab told you. A series of tests from karyotyping, FISH, and from PCR for known mutations. So now we have come to microarrays and whole genome sequencing and so on. So this is all a significant change in how genetics has been going. And paradigm shift in geneticist life, which diagnostic test rather than what is the diagnosis. Initially, all of us used to scratch our heads trying to find out diagnosis, do a lot of reading, use databases, try to get to one diagnosis, and then find out where in the world somebody is testing this gene. Now, nobody takes that effort unless you're kind of training. So you say, okay, this is developmental delay, dysmorphism, let's order an whole exome, and the exome will give us a report, and then we will check the other way around. So whole genome sequencing as the first line test. What is your opinion?
No.
No? Sure?
Yes.
So early use would be cost saving with better diagnostic yield. There are people, and see, first, there are always going to be hurdles. There are always going to be issues that we all need to deal with. But what is the current thing? You do microarray, then you do whole exome sequencing, and the platforms for all these are different. So you can't use the same data and do whole genome sequencing in that, or you can't have the clinical exome data and then say that I'm going to do a whole genome, because whole genome contains intronic data also, which is not there in your exome sequencing. Non-hypothesis driven testing, so wide coverage. So madam just showed a slide in her talk that I see what mind knows. But if my mind doesn't know some vague syndrome, I'm not going to think about it. But it is a non-hypothesis driven test like whole exome or whole genome that is going to throw at me some diagnosis, and then I have to work my brains to find out where it is fitting. So people feel that instead wasting many months, why don't you just do whole genome sequencing? Diagnosis of more than one genetic alteration can come up. So in the whole genome, maybe you have tested it for something, X condition, you might get information about Y and Z also. Some of them could be pharmacogenomic variants that will tell you that certain drugs are bad for you, or you need more dose of this drug if you use it. There could be predictive secondary variants. Yesterday, we saw a case where a Charge syndrome boy also was heterozygous for ATM carrier status. So you might discover a BRCA1 gene variant. You don't know. Now, whether you want to do that, whether you want to know that information is a different story. But how whole genome sequencing can help you? One-time genetic test. And you can revisit the data again and again at different points in life. If you need future interrogation, you can do the interrogation again and again, because that is the complete data, complete as of today. But what are the shortcomings? First and foremost is cost. Second is requirement of data storage and analysis. So even the companies, if there is so much of data, who's going to store it and then retrieve it also? Turnaround time is longer when in an ICU or in critical situations, you want the test as soon as possible, the test reports. Now people have reported 2 days for whole genome, but that's okay for one sample. If everybody starts doing whole genomes, I don't know how much of that will remain true. So rapid genomics in NICU, there are papers already published about WGS or whole exome plus mitogenome. So there are many companies who have fancy names for such things like Exome Max or something like that, which tell you that that is exome plus mitochondrial. Because in NICU, so many babies present with acidosis and related kind of situations, it could very well be a mitochondrial disorder that you will miss in WES. So what is known? We know that all sick newborns, there is a high impact of monogenic disorders in this perinatal and neonatal period. Infants with genetic disorders have disproportionately longer hospitalization and more mortality. Acute management decisions have to be often taken, and delay in initiating specific therapy is there if we don't have a diagnosis. So suppose you have a baby who has fallows or some conotruncal defect, and the parents are not really affording, they're not sure whether they can afford surgery, is NICU management. And if you on top of that tell them that this baby also has a 22q microdeletion, the whole situation for the family changes, because now the child's correcting just the cardiac problem is not going to make the baby completely normal. The baby may continue, will have developmental delay, there could be psychiatric problems, there could be intellectual disability, and the family might think otherwise. They might say that we want to do nothing and take the baby home. Again, we are not talking here about right and wrong and ethics and all that. This is just giving information, and that might change families' thinking. So having rapid results in NICU or in PICU critical situations is very important. And diagnosis of a causative genetic disorder has been reported in 57% of such patients. I think that's a great number if that's true. And de novo dominant mutations were found to be most common, which is also a good thing, because if they are de novo dominant, then the recurrence risk for the parents is also very low if they lose that baby with a very severe disorder. And this is going to help you, as we said, for specific treatment or for palliative instead of aggressive care and so on. So this was published way early in 2015 and another paper in 2021. So which disorders should be included if we wanted to do NICU rapid genomics? Actionable early onset, where there is strong genotype-phenotype correlation, availability of population-specific variant data. And why that is important? Because otherwise you will keep on getting lots and lots of VOUSs. And having a newborn with acidosis and 10 VOUSs, management decisions will be very difficult. So on-floor management is going to be symptomatic, obviously. But long-term management, you will be in trouble. There are complexities for this. Informed consent, defined criteria for reporting incidental findings, like in a newborn, if you diagnose a very easily treatable condition, let's say biotinidase deficiency, which is very relatively easily treatable, but at the same time you also diagnose BRCA1 variant or some other Huntington's mutation, etc. How are you going to, whether you are going to tell you, and how the family will take it? They are currently trying to deal with this newborn, and what the problem is going to be treated with one small tablet. But you are sending the baby home with these two new tags, and how one will deal with it? Or you will not give that information until that child becomes 21, and then ask the child whether they, that adult that time, that do you want to have more information from your genome, and so on. Cancer genetic testing is progressing very, very rapidly. And often there is somatic or germline alterations in the DNA. And now there are NGS panels to detect actionable mutation that will help oncologists to diagnose and select potential treatment regimes. So actionable is mutations conferring sensitivity or resistance to either approved or experimental target agents. Now this comes more from US papers, where there are many trials going on, and patients can be enrolled in trials if such mutation is there. And their insurance companies will approve of that, even if the patient is in a trial. Histology, so basket clinical trials based on molecular profiling of the tumor, irrespective of tumor type. So instead of saying this is a lung cancer or breast cancer or whatever cancer, you target the molecular problem there and say that this is a cancer related to this particular gene mutation, whichever kinase or whatever it is, and then the therapy could be based on the target rather than the organ. Tumor mutational burden, that also can be understood. Molecular tumor board, I think must be already there in your own hospital, if you're working in a bigger hospital. And genetically informed treatment options. So all big oncology units generally have a tumor board where the surgeon, pathologist, geneticist, the cancer geneticist, everybody is a part of that. and whether a patient deserves a clinical genetic, a genetic test, and whether the drugs will change, the chemotherapy will change, is all based on that decision. So preferably you need fresh and large enough samples, simultaneous testing of peripheral blood to detect germline variants, because most cancer genetics deals with somatic variants that you find in that cancer tissue. But some of there could be cancer syndromes where that mutation will also be found in the blood of that person. And then use of liquid biopsies, which is coming up now. So cancer cells shed in circulation, so blood, urine, saliva, etc. So when you do NIPS, it's kind of, we are trying to assess the fetus through mother's blood. So similarly, cancer cells hidden somewhere in the body can also be assessed by using any of these, material, and you can still do diagnosis. Now there is diagnosis as well as assessing residual cancer burden. What is the failure? Low quantity DNA, the same thing that comes up in NIPS. And what are the limitations? There can be undruggable alterations, or there could be gaps between patients with actionable mutations and available genomically matched therapy. And of course, there are going to be VOUSs whenever you start doing cancer genetic testing. Then we talked a bit about this yesterday, expanded carrier screening or reproductive carrier screening. And historically, it has been offered to subpopulations of disorders with high frequency in those populations. So Ashkenazi Jewish population, or if you're in UK, you get tested for cystic fibrosis and so on. So in India, which things you will test universally? We would like to say, yes, thalassemia, SMA, and such things. So, but with changing scenario, we have advanced technology, difficulty in assigning a single ethnicity. It's very hard to say that this person now belongs only to Dravidian category or Indo-European or whatever, because now a lot admixture is also taking place, especially worldwide, in India slowly. And so this particular technique can find out what all carrier status people could have, and if they want to have children, what they need to be aware of and what their spouses might have. And approaches differ, number and types of diseases. We saw this yesterday, which disorders should be included, individuals to whom they are offered. And I think we discussed most of it, that even if you know that you're not a carrier of any of the tested disorders, there can be some genes which are not tested at all. There will always remain residual risks of new mutations, and there could be low-grade somatic and germline mutations which are not going to be tested in that sample. Options of testing the partner has to be there if you want to do a recessive mutation testing, because just knowing your own recessive mutation is not going to help. If you're thinking of having a child, then it is going to be your partner's mutations that are going to come into play. Otherwise, just knowing your own carrier status is not going to help. And how to use this information? It should not be a sword, double-edged sword. Okay, so we switch gears and come to assisted reproduction and genetic advances. So going beyond standard familial indications of genetic testing, to ensure reproductive autonomy following non-directive pre- and post-test counseling, universal option for consanguineous couple or those who have lost previous child, if they want to undergo this. And many, at least, I know more about Pune kind of practice. So there are IVF specialists who are getting this done already directly or through a geneticist, that whenever there is such history, they want to go ahead with reproductive carrier screening. And there are occasional people who want to get even the donor tested, as we discussed yesterday. May also allow treatments during pregnancy or immediately after birth when treatable disorders are included. These are all commercially available. So within a few years, you will be redundant. If a patient wants to get a genetic testing, patient will get it done. And if they don't understand after going through Google, then they will come to you asking, what is this? So be prepared for that. But it may provide a false sense of security, because more tests you do and all reports say normal, your confidence starts building that, okay, I have no problem. But then there could be problems, and one needs to be ready to face these kind of problems. So this is, I think, still a very fancy thing for us, but can happen in the Western world, so can happen with us also someday. Voiding of gamete donor identity. Now, if there is a donor gamete used, and then there is data on nearly every person's genomic data is available with somebody, and then they say that give me your DNA sample, and I'll see who's your real biological father or mother. Now that is possible when everyone's data is there, and then you can actually trace that this donor gamete has come from such and such person. I think it is too far for us right now, but that's what future is warning us. So this was my generation, or even before that movie, Kabhi Kabhi. So an adopted daughter goes back. I mean, there the person knows who her mother is, and then she goes back to her mother's family, where there is another daughter with a new husband, and then that creates quite a situation. So all these things can come up. You all know about wiki donor, I think. So one day there is a gathering, and he knows that so many babies are there, which are all his babies, and then he feels very proud about all that. So when both parties agree to find genetic relatives, that is not impossible. DTC is the direct-to-consumer testing, and that can have accidental discovery of relatives. If everybody had been tested, children may find out that they are donor gamete conceived, and unless this is really told to them. Advances in male and female infertility. So gene panels beyond standard test as karyotyping. So today, if an infertile couple comes to you, you do karyotyping, most of you would do. But then you don't do any further test to find out what genetic test I'm talking about, to find out why they have infertility. But that could be helped. Pharmacogenomics, using drugs or dose to avoid ovarian hyperstimulation in IVF cases. Pre-implantation genetic diagnosis. I think we talked about it, and even yesterday and during the course, somebody must have discussed this with you. So there are always going to be challenges of embryo mosaicism. So it's more of a ranking tool to reduce reproductive implantation failure and miscarriages, but that is not final diagnosis. You need to do an invasive test like CVS or amnio and confirm it at that stage. And currently, it is only for disease-causing mutations, not to select traits otherwise. Yesterday, we just discussed about HLA. But somebody could then say, I want a taller baby, and I want curly hair, and I want fair color, or whatever. So this is not build a baby program. Okay, so this has to be restricted and by clinicians. Pharmacogenomics, you possibly already know. To select a drug, select dosage, safe, effective, and cost-effective also treatment. So there are gene panels based on actionable drug-gene interaction, providing therapeutic recommendations. And it could be implemented in routine clinical workflow also. Now, I don't know if there are people in medicine here or oncology. In my hospital, there is a group of doctors now developing that before warfarin, before starting certain drugs like statins, and also some anti-epileptics, people are now coming forward and doing pharmacogenomics, so that the side effects and all these things are reduced and you get a better choice of drug. So standardization of variants to be tested needs to be done, because every population might have subtle differences. So a test developed in the Caucasian population might not perfectly apply to us. So in the coming years, you could just print out a genetic profile, genetic disease or condition, and what is your risk status. The computer will tell you everything because you have fed the data, obviously. So severe adverse reaction, your risk status, no risk detected. Risk of adverse reaction to statins, high risk of adverse reaction. So avoid using that drug in this patient. Aspirin effectiveness or warfarin dosing, whatever you want to put in. And because your data is already there, which means that your genome has been tested. or at least certain disease related drug SNPs have been tested. This is going to be possible. And like your history, medical history, this is going to be a part of your treatment. And I think, although we have been saying this since the onset of Human Genome Project data, it has not yet become the practice. But I think in another 10 years, it could become a practice, at least for certain diseases. Gene therapy, you have had talks about it, I think, so I will not again go into details. These are going to be questions for many more years. Is it lifelong relief? And what about the immune response? When will the cost come down? We don't really have all the answers, but there were no such drugs 10 years back, and now we at least have some hope. So with every decade or every 5 years, I think there are going to be bigger and better leaps on this front. And maybe we can actually have some real gene therapy for patients. So vaccines of new era, COVID-19 has made I think whole of India aware of what PCR testing is, because of its nuisance value sometimes and because of its need sometimes. So there are going to be more and more such vaccines where the mRNA will be used, or some such technologies will be used. And you know now that within a 1 year span, such large quantities of vaccines could be produced. And I think that is because of advances in genetic engineering and genetic technologies. All these were possible. Direct to consumer testing, if you start Googling that you want to do some genetic test without a doctor, you want to directly order a genetic test, you will get many such companies. I have nothing against or towards these companies. I just found these on the net, so I put them here. So it's commercial genetic testing offered over the internet. It's persuasive marketing, use of kits suggesting medical legitimacy. Genetic information is projected as your empowerment to your health, which is true to a certain extent, but not always. And you need to participate because you are a responsible person, a positive behavior or contribution to science, etc. So under all these premises, you are encouraged to do genetic testing, learn more about oneself, help improve the predictability of a genetic testing, or consider it fun to explore genotype and phenotype data. Where are you from? And then there are concerns, because adequacy of consumers' informed consent is a question. What sort of consent do you sign when you do these tests? Transparency of companies' research initiative. I think Greenland and a couple of other countries, they apparently have genomics of each and every citizen of theirs. And suppose some company wants to sell that data based on to develop newer drugs, newer markers. For us single doctors, it doesn't really mean anything, but for companies and nations, it could mean a lot. And then privacy and confidentiality of whatever information you are providing through that saliva sample. One needs to really be thinking twice before doing such kind of tests. So this is, I think, my last slide. We used to say with fun that genome kundali honi chahiye. Before marriage, people somehow go and do their blood groups only, and then they have a lot associated with blood groups, same hai ya different hai, and they have their own notions. So everybody does blood group testing before marriage, or sometimes they do HIV testing before marriage, etc. So people, why not have a genome kundali at birth itself and then compare it maybe? So everyone's genetic information, genomic information is known at birth. So population whole genome sequencing, just think of it. Behavior and lifestyle modifications for ecogenetic disorders, and surveillance for late onset disorders. So kaise hoga aapke bacche ka future? Now you have a genetic test. If you wanted to challenge the Jyotish, marriages and matchmaking in carrier status testing. And the genome can be interrogated again and again. So later on, if there is cancer development, you can always go back. So agar mangal dosh hai, to ye karo. So similarly, if you have some problem in your genome, go and get it fixed or do something about it. Drug choice as suggested by pharmacogenomics. So kundali mein cancer ka karan wa upay. And these are all real things, and these are happening, right? So I think as doctors, we should have something strong to challenge this Jyotish, or at least compete with that. So transgeneration use of information to pass it or not to pass it. So what is the optimistic way ahead for doctors? Education, interdisciplinary teaching, and I'm very glad that these type of courses are happening and SGPGI is doing that, so that so many different faculties are here who can also get introduced to genetics, and then it is up to them whether they want to pursue it further. Not becoming a geneticist as such, but even in your own practice, you can have adequate genetics data incorporated. Better clinical practice, inclusion of genetic aspects and testing when necessary. Scientific communities need to come up with cheaper and widely available genetic tests, therapies for genetic disorders, vaccine productions, because that's going to be a big challenge. Public and government, lots of things, advocacy groups, collecting data, and mostly politicians' attention for policy decisions. And it's not completely zero on that. They are also getting better if we give them good information, good statistics. So that's it. Thank you.